Morning, everyone. Welcome to our May webinar. And I thank you for joining us for this Knockout Opioid Abuse Day Learning Series webinar, Treating Pain Without Opioids. I have quite a bit of housekeeping to get through today because we have a new certification that we're offering for today's webinar. So bear with me. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, 1 ADA CERP continuing education credit by the American Academy of CME, Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for 1 EMT elective CEU. The Partnership for a Drug Free New Jersey is approved for this webinar by the Board of Certification, Inc. to provide continuing education to athletic trainers, ATSs, and this program is eligible for a maximum of 1 Category A hour for continuing education unit. So we welcome any athletic trainers who are with us today for this credit. Please be aware that there are different links to each type of credit that is being offered for this webinar. Since we have so many, please take a look at the slide that you see now and make sure that you go to the correct links to apply for the credit that you need at the end of the webinar. As noted on this slide, the links will be provided at the end of the webinar and in follow-up emails that you will receive. And you should receive those emails tomorrow. And lastly, PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson. But all other faculty and planners have nothing to disclose. Today's webinar is jointly provided by the Partnership for a Drug Free New Jersey and the American Academy of CME, Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And once again, I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to welcome today's expert speakers. I think the topic we're discussing today is so crucial to our discussions that we have all year long regarding the opioid crisis. And so I welcome Dr. James Bailey, the chair of Neuromusculoskeletal Institute at Rowan Virtual School of Osteopathic Medicine, and Sarah V. Sorrento, a nurse clinician at the John Thawer Cancer Center at Hackensack University Medical Center. And I welcome you both, and I thank you for being with us today. And Dr. Bailey, we'll kick off with you, and I'll turn the presentation over to you right now.
Hey, thank you very much, Angela. It's my pleasure to be able to speak to everyone today. So for the next 20 minutes or so, I'm going to speak about how we can treat pain without quote unquote opioids. And the reason why that is in quotes is because I'm going to be talking about a different type of opioid that really hasn't reached, I would say, common practice in utilization for acute and chronic pain management. Next slide. I had no disclosures. Next slide. Just some background about myself. My undergraduate's from the University of Scranton in Pennsylvania, and I attended Philadelphia College of Osteopathic Medicine and followed that in residency, a joint residency program between Temple and Moss Rehab in physical medicine and rehabilitation. And next slide, please. So at the conclusion of my session, learners should be able to better explain how opioids work and their effects on the human body and identify non-opioid medications and practices which can be used by the care team to treat acute and chronic pain. And next slide. So the question that we all have for chronic and sometimes acute pain, to prescribe opioids or not. And that's, there's a lot of thought that has to go into this. It cannot be a knee-jerk reaction when a patient complains of pain. Next slide. So if you're considering prescribing opioids, particularly in the state of New Jersey, it's good to have some of this information. So the highest county rates of prescribing opiates, Salem County 50, Cape May County 46.9, Atlantic 46.4, Camden is right there. Interestingly enough, though, the amounts of opioid abuse and overdoses are also high in southern New Jersey, but also high in eastern New Jersey. I know Essex County is one of the largest. So what that means is that those opioid overdoses are not coming from prescription opioids, but we had to be mindful because we could be supplying, we are supplying patients with these. And next slide. So from 2012 to 2022, we have seen the opioid prescription rate decline from about 60 prescriptions per 100 residents down to around 28.6. And that can be a good thing, but to keep in mind, we are allowed to prescribe opiates as providers, and we can do it safely, which is why I'm speaking to you today. It's also important to note that opioid prescriptions dispensed by age group. So we can see a very large amount are prescribed to people from the ages of 45 up to 74. Okay, so middle age up to Medicare age patients. And that's a population that we really have to be monitoring and be concerned about, that we are prescribing safely. Next slide. So how do we prepare ourselves and the patients if we think that prescribing opioids are going to be within that patient's treatment plan? The important thing is to screen them. Okay, so to use the SOAP-R, which is screening for opioid risk and misuse. It is a 24 question questionnaire that can be done in the office, and it not only gives you information about opioid risk, but also gives you more insight into the patient's history. GAD-7 for anxiety, PHQ-9 for depression, pain catastrophizing scale, when no matter what you do for a patient, nothing is working. And that can really put that patient's presentation into context and help you decide, what the next best plan of care is for them, whether it be prescribing controlled substances or not. And maybe there's an underlying anxiety disorder or depression that has to be treated. And when that is treated, then the pain begins to improve. If you are considering prescribing, you should be checking a urine drug screen, and we'll talk more about that because urine drug screens measure compliance, and whatever we measure, we can then manage. What we really see in prescribers of opiates is that those who are not checking urine drug screens are not really maintaining compliance, or they're not assuring compliance that the patient is taking what they're being prescribed. The next is checking the New Jersey prescription monitoring report. And anybody who is considering prescribing any controlled substance, whether it be opioids or benzodiazepines or potentially amphetamines, you have to check the NJPMP to assure that you know what medications or controlled dangerous substances, CDS, that the patient is receiving, from whom they're receiving them, from what pharmacy they're receiving them, because that is going to, again, play into the context of treating that patient as a whole. The next, that you could monitor for any triggered or conditioned responses to any stress, such as the stress of surgery or pain exacerbation. So you get to know your patient and understand if this is a normal response for them or not. Next slide, please. So it's important to know in New Jersey, urine drug screen testing is required annually. Within our department at the NMI, or the Neuromusculoskeletal Institute, we use urine drug screens quarterly or randomly as needed if we suspect there is some misuse. So if we do receive an abnormal urine drug screen, we then bring the patient in for a random pill count, giving them 24 hours to present to the office, and we repeat the urine drug screen. It's important to, and we'll talk more about that, but it's important to note too that if there's alcohol present, you have to ask the question, does the patient have a history of diabetes? Is there glucose present in the urine? So we are not falsely accusing a person of utilizing alcohol while also taking opiates. So that would give us an explanation. I've had some patients who have been diagnosed with diabetes because of presence of glucose in their urine drug screens. And then it's also important to note what other medications, some medications that treat diabetes actually cause glucosuria. And they may be very well controlled or may have very well controlled diabetes. However, the glucose that is a side effect of the medication is fermenting within the urine sample before it's tested, causing a positive alcohol. If there's marijuana present, we ask, does the patient have a medical marijuana card? Even though medical marijuana or marijuana is legal within the state of New Jersey, we also recommend that patients obtain a medical marijuana card for whatever condition that they are treating. So they are not, so we know that hopefully that they are obtaining it from a dispensary at particular hours and given particular products, and they are not buying it outside of that. Next slide, please. So this is just a review of all of the full mu opioid receptor agonists that we can potentially prescribe. And I will talk about the metabolism of these, which is extremely important. But this is a quick overview that I'm sure many people have seen, both the generic and I have brand names here, just so you understand where those generics are coming from. And it's also important to note that these all come mostly in short-acting and long-acting forms. And next slide, please. So whenever you're thinking about urine drug screens, you have to understand opioid metabolism in order to properly interpret urine drug screen results. So if we start with, we'll say, the prodrug codeine, okay, that gets metabolized into morphine. And we'll just keep following the arrows. High doses of morphine will and can be have a minor pathway, a metabolic pathway to hydromorphone. Therefore, if somebody is prescribed codeine, we should see morphine in their urine. If someone is prescribed morphine, we may see small amounts of hydromorphone. If somebody is prescribed hydrocodone, take that codeine or codone root, and hydrocodone is metabolized into hydromorphone. So it is absolutely appropriate to see hydromorphone in a urine drug screen for somebody who is being prescribed hydrocodone. The same effect on the synthetic side, oxycodone is metabolized into oxymorphone. So we should see those metabolites. If we do not see those metabolites, that's a problem, because that either means that the person just took the medication prior to coming in, and they haven't been taking it regularly because the metabolites are not there, or there is a potential diversion or implanting a pill of, we'll say, oxycodone or hydrocodone or a small amount of that in their urine sample to make the test ring positive. And next slide, please. So it's also important to know that the tests are only as good as the provider who is ordering them, because you have to know what tests that you should be ordering. If you order a generalized basic opioid screening panel, that they typically only test for morphine-based products. That means that they are that test is going to be a false negative if the patient is also taking oxycodone, tramadol, fentanyl, methadone, and buprenorphine. So at Rowan Virtual School of Osteopathic Medicine, we are in the process of educating all of our providers on what urine drug screen panels they should be ordering in order to obtain the correct results afterward. Because if you just order a basic opioid screen and it comes back negative, but you're prescribing the patient oxycodone, that's a problem. Okay, it doesn't, just because you order the test doesn't mean that you've done your due diligence. You have to go back and make sure that that person is remaining compliant with this. And next slide, please. So what the main topic of my session is today is talking about buprenorphine and its use for both acute and chronic pain, because we have found that buprenorphine is a partial mu agonist. Okay, that means that, as you see on the right side of the screen, that it only partially activates the opioid receptor. Okay, unlike methadone, that is a full agonist, and unlike naltrexone or even naloxone, that is a full opioid receptor antagonist. And because it is a partial mu agonist, it has a ceiling effect for respiratory depression, but not for analgesia, meaning that it is extremely safe to prescribe in terms of respiratory depression. So, and it's a partial mu receptor agonist at the spinal cord level, which is key for limiting respiratory depression. It does not affect the brainstem and doesn't have any more reinforcing effects that we will talk about. Next slide, please. So buprenorphine has a very high affinity for the opioid receptor, meaning that it binds to it very strongly. That also means that if there are any other opiates within the system, that it will bump those off of the opioid receptor and take its place. That comes into play when we are prescribing high-dose buprenorphine for patients with opioid use disorder and in causing precipitated withdrawal. In the chronic pain population, we really don't see that as frequently, if at all. On the right, this is an important comparison between buprenorphine and fentanyl. So the probability of analgesia, as that is increasing for buprenorphine, the probability of respiratory depression sharply decreases. And that is the exact opposite of fentanyl, that as the probability of respiratory depression increases, the probability of analgesia goes down. And next slide, please. So these are some of the effects that buprenorphine has on the various opioid receptors and why it's so important to consider utilizing within your treatment regimen before going to full mu agonists, such as morphine, oxycodone, hydrocodone, or fentanyl. So when it partially activates the mu receptor, it offers potent analgesia, as I said, a ceiling effect on respiratory depression and euphoria. Anytime I prescribe this to patients, I educate them that they will not feel the medication, quote unquote, kick in, because it does not cause the same euphoria that full mu agonists will cause. In patients who have previously had those before, they will be looking for that and deem this medication a failure if they do not feel that. But we really try to educate people to think about their function rather than the level of their pain. So this also, because it's a partial agonist, has limited impact on GI motility. So less instances of opiate-induced constipation. There's less physical dependence and abuse potential because of the lack of euphoria. There's reduced immunosuppression on the hypothalamic pituitary axis, and there's also a reduction in suicidal thoughts, anxiety, limited depression, and dysphoria. The other two key points is that that buprenorphine antagonizes the delta and kappa opioid receptors. So the delta receptor the antagonism has very similar to the effects as the partial agonist effect of the mu receptor, but the antagonism of the kappa receptor really helps with decreasing any effects of opioid-induced hyperalgesia. And that means that when patients are prescribed opiates, sometimes even a small amount for an extended period of time, they can develop symptoms of worse pain. And that, to the uneducated provider, that they may increase opiates, and that is further taking that patient down that vicious cycle. Whereas if we're seeing more pain on opiates, we should consider opioid-induced hyperalgesia in the back of our mind, and the only way to treat it is to decrease the full mu agonist. But buprenorphine does not cause this. Next slide, please. So I would be remiss if I did not talk about this, just regarding buprenorphine in the treatment of opioid use disorder. So I will just quickly move through this slide, but it's extremely important, these numbers. So this is 1-year mortality rate after naloxone is administered by EMS. So two groups, those who had passed away within 3 days of the overdose after being administered Narcan, okay, their mortality rate was 8.3%, and those people usually passed within the hospital. Those who died within 4 days to 1 year, they typically that was going to be out of the hospital, and that was 6.9%. So the total mortality rate for patients who were just treated with naloxone or Narcan is 15.2%. That does not include anybody who's treated with buprenorphine. They were not. So that's a huge number when you consider the total 1-year mortality rate after an SC segment elevation MI with an intervention. That's only 7.3%. Okay, so it really should kind of change your mindset that that the medical teams rush for a patient with a myocardial infarction. However, we don't do the same for people who are coming in with opioid overdose. And next slide, please. So if you were going to initiate this, and I'll talk about the types of buprenorphine that you can prescribe, you can taper less than down to 30 morphine milliequivalents. I will say anecdotally, I have patients where I have not taken them as far down, and there has been no signs of precipitated withdrawal. And then as you are tapering somebody down, you have to add other things in, okay, to make sure that their symptoms are still being covered. One of the things that I treat 99.9% of my patients with is osteopathic manipulative treatment. And I'll talk about that briefly. Neuroleptic agents such as gabapentin or pregabalin, serotonin, norepinephrine, reuptake inhibitors such as duloxetine or milnacipran, muscle relaxants such as baclofen or tizanidine, NSAIDs, if appropriate, acetaminophen, and physical therapy to keep people moving. And next slide, please. So these are 2 brand names that are available. And I believe the transdermal is now generic. So one is Butrans, that is a 7-day transdermal patch. So the person is prescribed 4 per month. And the second that comes in higher dosages is a buccal formulation called Belbuca, and that is dosed every 12 hours. Well, I know Belbuca has very easy to follow administration instructions in terms of what morphine milliequivalents the patient previously was on and what the starting dose of that would be. And the good thing about both of these, you can really change the dosage. You could really change the dosage in about an interval of every 3 to 4 days to titrate that patient up to an appropriate level that their symptoms are being controlled. And next slide. On the other end of the spectrum, in much higher doses, so it's important to note that Butrans and Belbuca are prescribed in micrograms, but medications like buprenorphine/naloxone or brand name Suboxone or Zubsolv, or there's many others, they're prescribed in milligrams, so in the thousands of micrograms measurement, as opposed to a few hundred micrograms the Butrans or Belbuca. And next slide. And next slide. Thanks. So this is the buccal formulation dosing for Belbuca. You can use this in addition to full mu agonists for breakthrough pain. So it's important to note at the top of the slide that the dosage that I'm talking about is 0 to 2 milligrams, okay, for Butrans and Belbuca. However, it can go all the way up to 24 milligrams when we're treating opioid use disorder. And this is available right on the Belbuca website. And I think that it's extremely useful. I refer to it often. And next slide. So some clinical pearls, and we'll also have some more time for questions. Used as a long-acting agent, you can also use it as a short-acting agent for postoperative pain, and it can be used with short-acting opiates. Okay, peak concentration typically occurs around 60 hours, steady state at 72, and prescriptions can be refilled because it is a Schedule III. And next slide, please. So just to review compliance measures. So any difficult or challenging cases that you have within our department, we have once a month peer review groups where we unify our patient approach. We review the PMP at every visit, urine drug screens every 3 months or more, pill counts and repeat urine drug screens, warning letters and counseling. We limit the quantity of medications prescribed. The max that we will ever see somebody is every the max is every 2 months. We will not let anybody go out to 90 days, which are Medicare guidelines. And then we also have embedded behavioral health within our department. If you don't, that's okay, but make sure that you know where to refer people to. And next slide. And again, I would be remiss if I didn't talk about this more in depth, just for one more minute. So osteopathic manipulative treatment, I said I treat most of my patients with this diagnosis and treats somatic dysfunction, that is dysfunction within the musculoskeletal system. It is not seen on imaging. It's not detected in lab work, but it is detected by honed physical examination skills and palpation. And the importance of that is that it really validates patient complaints when everything else is negative, and they come to you and they say, listen, everything's negative, yet I'm still in pain. And we can often allow the patients to leave the office with less symptoms. And just as a quick note, at the bottom is an article that we published back in 2021 with a cost comparison. And while we didn't find any major cost differences between the osteopathic manipulation group and standard of care and the standard of care group, there was much less utilization of medications, interventional pain management, radiology studies, and surgeries. So this really can help people more than prescribing medications. And that is the conclusion. I'll be available for questions afterward.
Thanks so much, Dr. Bailey. Great information. And I know Sarah's going to pick up and talk about some additional alternatives. And then at the end of Sarah's presentation, we will take some questions from both of our expert panelists. So Sarah, we'll turn the presentation over to you.
Thank you, Angela. Thank you, everyone, for having me. I'll be discussing alternatives to opioids for pain management today. I am a holistically board certified nurse through the ANCC. I've been nursing for about 11 years now. I work at the John Thoreau Cancer Center, and I have a history. My career prior was in surgical, in urology surgery, and solid organ transplant. So I have a lot of experience in surgical pain and also oncology pain. Next slide, please. Just a disclaimer, this presentation is informative and educational. This is not individualized medicine, which is always the goal. Individualized plan of care is the most important element about pain management. So if you are a patient or are listening to this talk for a patient, please be sure to consult your individualized care provider. Next slide. You can do that. Next slide again. Okay, so learning objectives, the goal here is to implement pain preparation strategies to improve pain management in post-procedural areas, surgeries, and interventions, and reduce the overall use of opioids. The goal really is to develop an individualized plan of care with each patient and get them involved in choosing which drugs are appropriate for them and how they're going to manage their pain depending on the type of intervention, and incorporating effective non-opioid pain management techniques, pharmacological and non-pharmacological. And the learning objective is to describe the safe use of opioids, including strategies to minimize adverse side effects and use, considering the fact that we do need to use opioids in our practice. We just need to ensure that we're utilizing them appropriately. Next slide. This was very well covered by Dr. Bailey, so I'm going to go over this real quick. There are 3 opioid receptors, which Dr. Bailey discussed. The common agonists that bind to the mu receptors are the drugs that you're going to see that cause analgesia with side effects of sedation, respiratory depression, bradycardia, nausea, vomiting, and decreased gastric motility. So those are the drugs that are most commonly known, but the drugs that we really want to use as best as we possibly can in a multimodal method by using other drugs. Next slide. So if you were going to run a marathon, you would train for it. Training for pain is something that is not really discussed often, but is something that needs to be brought up more regularly in conversations with patients prior to interventions. So the training regimen should be appropriate to the severity of the marathon. The planning for pain should be appropriate to the severity of the intervention. So pre-operatively or pre-intervening, we need to have a conversation with the patient what they should expect. If they're going in for a massive surgery, We need to be telling them the different types of pain. What kinds of pain are they going to have? If they're having abdominal surgery, we need to prep them on gas pain, on shoulder pain. How long of a recovery? What are the tools to reduce pain? What are their prescriptions going to be? As much conversation as we could possibly have with these patients prior to them coming into the facility for this intervention, it will decrease their anxiety about the procedure itself. It will make them feel empowered and part of the plan of care, and will really help promote them utilizing those non-opioid pain techniques because they already have heard of them. It's very challenging if you have a patient who comes in for a surgery and post-op day 0, immediately 45 minutes after waking up in PACU, they've never heard of IV Tylenol. And the PACU nurse is trying to administer it, and this patient's never heard of it. They're going to maybe feel like they're not part of the plan of care. If we're empowering our patients with this information prior to the surgery and developing that plan with utilizing non-opioid management techniques prior to them coming in, the patient is decreased anxiety, they feel like they're a part of the plan of the care, and they might have a better sense of control over the pain itself. Next slide. So the pain self-assessment. This is the Wong-Baker-Faces pain rating scale, which you might see if you are in the hospital or if you've had any kind of done any research on pain management. This is a very popular scale. It was developed by Dr. Donna Wong and a child life specialist, Connie Baker, for children. The original concept was that in the pediatric population, children were having a hard time describing their pain. However, in modern medicine right now, this has been criticized. In 2021, the functional pain scale was seen to be more beneficial for patients because pain as a number can be very hard for patients to get a grasp on how it's impacting their life. The functional pain scale, on the other hand, shows what level of pain is impacting their function. And sometimes it can keep patients away from that harboring on a number or harboring on a time, and it rather empowers them and shows them that even with some pain, they can still function and that their activities of daily living are not decreased and that they can overcome the pain and continue to live their life, which can decrease the use of medications because patients now feel empowered that the pain is not stopping them from doing something, but they're functioning around the pain. Another limit to this scale is also the average amount of pain that a patient feels within a 24-hour period is often more important than the peaks of their highs and the peaks of their lows. And when you're having a conversation with the patient about pain, especially if it's an acute issue, sometimes it's challenging if the patient is in that moment of, let's say, a 6, a 7, or an 8, but their 24-hour average has been very well controlled. And if they're looking at a pain scale, sometimes they have the tendency to focus on those peak high moments of pain. When if you're having a conversation with the patient, explaining to them how the average over 24 hours is really what you're looking for of better control, sometimes it takes away the element of the patient feeling like those peak highs are so terrible that that 10 out of 10 has to be the worst time of their day, when this pain rating scale sometimes is criticized because it can really focus on those peak highs. And there's also a limit because patients with cognitive defects have a challenging time with this scale as well. Next slide. So we discussed preparation. I think preparation is one of the biggest things that I have changed in my practice in preoperative conversations with patients. When you're scheduling procedures, it can be something so simple as in the oncology world, a bone marrow biopsy. To anybody who's received a bone marrow biopsy, you're aware that it's painful. It might not be something that's a 10 out of 10 pain for one patient, but it can be a 10 out of 10 to somebody else. So preparation and scheduling is extremely important. Family and friends support should not be looked over. It's very important to make sure that these patients have somebody that can take them to and from a procedure so that the patient feels supported. Ensure that the patient has a caregiver at home. These conversations might seem like they're outside of surgical planning, but without those elements, patients are much more likely to turn to the pain and only focus on the pain because they're by themselves. They have no support. They have no one helping them go about their post-op recovery. It's very important to do a thorough Q&A with the healthcare team and establishing individualized patient goals. So what is the patient's goal for recovery? What is their functional goal? For example, abdominal surgery. I'm just going to go back to that because that's where the majority of my years of experience have been in. You have a patient with a prostatectomy, and their goal is to return to golfing in 6 weeks. That gives the patient a concrete idea to hold on to, and you can use that goal and you can attribute their progress to getting over the pain, in the sense, to recovering with the pain of working towards that goal. So, for example, abdominal pain after surgery is often related to not ambulating appropriately. So, if you know that patient and you've created an individualized plan of care on post op day one, you can say to that patient, I know you want to golf in 6 weeks. It starts here. It starts with ambulating 5 times a day right now. So that just psychological preparation and that really getting to know your patient is incredibly important. It's also incredibly important to talk to your patient about their self-awareness of their pain tolerance. So there's a element in preparing to have a natural delivery of a baby that many mothers will do a test that's called the ice test, where in each hand they take an ice cube and they squeeze it really tight. And they time themselves of how long they can hold that ice cube. And they start out with one hand for 10 seconds, then that one hand for 30 seconds, then that one hand for a minute, and then 2 hands. And eventually they build up their pain tolerance to get up to a minute in anticipation of a minute contraction. That conversation can also be had with a patient who's going into surgery. The conversation can be, what is your pain tolerance? Have you had any kind of pain before? Have you experienced pain before? Are you somebody that has been self-aware of how quick you are to treat a pain pharmacologically? And that's a very important question. Is this a patient who is the first person to take 1,000 milligrams of acetaminophen for a headache? Because if you're trying to use 1,000 milligrams of acetaminophen for abdominal pain, and this patient has been taking 1,000 milligrams of acetaminophen for a headache every 6 hours for the past 3 days, that could be a challenge. So it's very important to understand what that patient's pain tolerance is and what are their individualized comfort measures. So what does this patient do when they are in pain that's helpful? So you, as their provider, knowing and understanding what decreases their stress and what comfort measures works for them, that can carry over into the post-operative world. So you know that this patient likes soft music and loves scents, or this patient likes Metallica. That can be something that you can utilize, especially in nursing care post-operatively. We also use it in oncology now. We ask our patients, for your bone marrow biopsy, what music would you like to listen to? And those individualized comfort measures, they develop rapport with your patient. They develop a level of comfort with the patient. They decrease stress, decrease anxiety, which can decrease their perception of pain. So sometimes the intervention can't be less painful. I can't make the bone marrow biopsy less painful, but I can decrease the patient's perception of the pain. Next slide. So preparation physically, it's also important to tell your patients you want to be in the best possible shape that you could be prior to going into this intervention. So for example, you're going into abdominal surgery, weight optimization, activity optimization. Are you in good health? Are you decreasing the stress in your life as much as you possibly can in preparation for this procedure? If you're coming out of a procedure and your mental state is extremely stressed over something that you could have managed prior to a procedure, that could increase your perception of pain. It could increase the anxiety and it could heighten the entire experience of the procedure, which is not the goal. And optimizing clearance organs, incredibly important to teach your patients. Please don't drink. Please don't take a lot of NSAIDs prior to the surgery unless they're prescribed. You just want your liver and your kidney to be in their best health, and quit smoking prior to any procedures, ensure lung function. And these are simple things, just conversing with the patient, explaining to them, if you have time, if you know you have 2-3 months prior to your surgery, get in the best health that you possibly could in the situation that you are in. And maybe it's walking around the block for one person, maybe it's running for someone else. It doesn't matter. It's just explaining to the patient that prior to surgery, working on getting into the best version of their health is going to make their recovery faster. And what's their home environment? Just preparing. So if you have somebody who's going in for a hip procedure, explaining to them that you would prepare the home prior to the procedure. So if you're going to be sleeping on the first floor, have a family member bring that bed down. Just assessing their discharge needs and their mind-body connection as a provider, preparation for their procedure. It's important to establish the conversation with them. Mind and body connection is incredibly important in your ability to control your perception of pain. So, do you practice mindfulness? Do you practice connecting to your body? Do you practice feeling your sensations? Do you practice assessing your own pain tolerance? And chiropractic maintenance, incredibly important for physical maintenance of the muscles and the ligature, and ensuring that that patient is going into the procedure as healthy as they possibly can be. Next slide. It's also important to, in preparation of understanding the opioid medications and their side effects, so explaining to the patients the risks of opioids, constipation, nausea, dizziness, confusion. If you're doing abdominal surgery with a patient, you need to be explaining to them the risk of an ileus and explaining to them that you could end up going back into surgery because of opioid use if you develop a small bowel obstruction. Explain to them the risk of dependency. Patients who have not used opioids before might not understand the risk of dependency. Many patients, their first experience with an opioid is after an athletic injury in high school and or getting their teeth pulled. Somebody who hasn't had major surgery and has only experienced an opioid, let's say something like a Vicodin, after getting their molars removed, they might not understand the concept that this prescription that they could be going home with for pain after their surgery puts them at a risk of dependency. So you need to have that conversation with them and explain to them that using an opioid based off of a clock is extremely risky. You do not want them taking a medication that is an opioid just because it is 4 p.m. You need to explain to them that this is something that they need to be empowered and that they need to prevent the addiction as well. Next slide. Describing to the patient the different types of pain is extremely important so that they know what they're going to get themselves into. Surgical pain, incisional pain, and gas pain. It's very scary and challenging for a patient when they come in for, let's say, an abdominal surgery and they have extreme shoulder and elbow pain. If we prepare them in advance and explain to them that gas pain is going to turn into nerve pain in their shoulders, they're not going to be as surprised. And the likelihood of them saying, I need more pain medication, my shoulders are killing me, it's going to go down. They're going to understand what they're going through. They're going to understand, I knew this pain was coming. The doctor already warned me. The nurse already warned me that I was going to feel this kind of pain. That means I have to get up. That means I have to mobilize the gas. Next slide. Depending on the type of pain, there's different pain management. So surgically, alternating acetaminophen and NSAIDs, such as ibuprofen or Toradol, is extremely helpful. IV acetaminophen, Oframev, is one of the most beneficial drugs used post-abdominal surgery. I would highly encourage anyone who doesn't have it available in their facility to advocate with their team because it is a game changer in post-operative care. Positional awareness. So patients that have had different types of surgeries, teaching them to avoid positioning that is, putting pain on their incision. It seems so simple. It seems like common sense, but somebody who's never had surgery before, they're not going to know that. So advocating for them as their provider is very helpful. Identifying triggers of coughing, sneezing, laughing. For example, teaching the patient how to splint after abdominal surgery. It's giving them tools that they can manage the pain themselves while you're not in the room. Following post-operative diets as prescribed, for example, teaching patients to follow clear liquids, avoiding constipation and ambulation is incredibly important after many surgeries, identifying triggers and encouraging them to ambulate as much as possible. Next slide. So pharmacological non-opioid pain management. The number one thing that we see that is incredibly important is acetaminophen, IV Oframev around the clock. Around the clock meaning you want to administer it every 6 hours, regardless of whether the patient is reporting pain or not, and explaining that to the patient, that this drug is being utilized to decrease those spikes in pain. Medications like ketorolac or Toradol, COX-2 inhibitors such as Celebrex. Lidocaine there's a lot of new research and interesting uses of IV lidocaine intraoperatively. It's being utilized to decrease the amount of opioid use post-operatively. Topical lidocaines are also very helpful. They come in many different forms. There's patches, there's creams, there's gels, there's foams. Just be mindful of the absorption and utilize your pharmacy teams. It's like less than 5% absorption, but you want to make sure these patients aren't putting more than 3 lidocaine patches on, because that is something that you can send someone home with a suggestion of using a lidocaine patch, but just ensure that you're educating them appropriately and talking to your pharmacist. Injections of lidocaine. So there's IV. There's injections that you can put the actual lidocaine into the area that is bothering the patient. It's been utilized in the urology world. It is something that you can talk to your surgical team about. Magnesium infusions. So magnesium is an antagonist of NMDA receptors, similar to ketamine, and it can be used intraoperatively to try to prevent the amount of opioid use post-surgical as well. Gabapentinoids, which Dr. Bailey did mention, like Neurontin and Lyrica. I do highly encourage that you discuss this with your pharmacy team, though, because there is a very high risk of polypharmacy with these drugs, especially in the older population. So utilize your pharmacist to review what other medications this patient is on before prescribing. Regional anesthesia, such as spinal subarachnoid blocks, epidurals, nerve blocks. A lot of ortho surgeries are using these, and they're very successful of utilizing nerve blocks. Ketamine is also used in intraoperatively. There's some new research on esmolol perioperatively. It is a beta blocker, but there has been some successful data on it decreasing the use of opioids as well. Precedex or dexmedetomidine, it's essentially like a perioperative medication, also being utilized in that perioperative cocktail to try to decrease opioids after. Anticonvulsants are nerve calming, so they've been used frequently. Carbatrol is one of the number one medications used for trigeminal neuralgia. We also have seen new research on valproic acid and headaches, so those can be used for different types of pain as well. Antidepressants, such as Dr. Billy mentioned, of SNRIs and tricyclical antidepressants, those can also be used in chronic pain patients. It's typically where it's seen, but sometimes you have these patients who have had, let's say, a major surgery, and now they're 6, 7, 8, 9 months down the road, and they're really in a bad mental spot. Antidepressants can be used to help decrease some of that post-operative struggle of socializing and of getting out and moving. And those things are so important for recovery as well. It's incredibly important to make sure that the patient has a quality of life. So sometimes antidepressants can be used in conjunction with chronic pain medications, injections and nerve blocks, such as in orthosurgery. Transcutaneous electrical nerve stimulation is also used sometimes in conjunction with acupuncture. So something to consider, especially in patients with back pain. Massage. A lot of tension headaches can be resolved with frequent massages. Biofeedback therapy is essentially giving the patient empowerment to understand why their body is doing what they do. It promotes relaxation, but it also helps promote the patient understanding what their response to that pain is. So it's something that's more long-term, but it is very beneficial for chronic pain patients because it helps empower them to see, why am I reacting to that stimuli the way that I am? Radiofrequency ablation is it's blocking the pain signals in the back. It's typically used for arthritis and back pain, as is spinal cord stimulation, which is a device that's implanted for back pain. And CBD and THC. So I just want to touch on this real quickly. This is not FDA approved. THC is a psychoactive component that is found in marijuana. It is currently, there's only 2 different products on the market that have THC synthetics in them, which are only approved for cancer-associated nausea and appetite stimulation. But there are products that utilize CBD that can be very beneficial for patients with chronic pain. Now, they're not FDA approved, so it is challenging. You can have patients that are using these products with very great outcomes, and we are not in the position to recommend them medically for a patient since they're not FDA approved and there's not a lot of research on them. But I just wanted to mention it here because especially in the oncology world, there are many, many patients that are utilizing CBD creams, gels, oils with a lot of great outcomes. So that's something that you have an honest conversation with your patient about, and connect with your pharmacist to make sure that it's not interacting with any of their medications. Next slide. So non-opioid pain management interventions. The number one thing that you have to recommend with all of these surgical patients is ambulation and movement. They are in pain, they don't want to move, but they have to encourage them and realize that the less that they move, the worse their outcomes are going to be. Utilizing hot and cold therapy, excuse me, alternating between ice and heat can sometimes be beneficial for different types of pain, especially lower back pain. And psychological control of the mind and body, helping empower that patient to realize that they can control their reaction is incredibly beneficial. You're not decreasing the pain is still there. You're utilizing the medications to try to decrease the pain as much as you can, but you're giving the patient the empowerment to realize that they have mental control over what their reaction to the pain is with using mind body techniques. Aromatherapy can be very beneficial. Scents like citrus and lavender can help decrease pain perception and help promote relaxation, which decreases cortisol levels, which can help decrease pain perception. Topical agents like joint support, something simple as wrapping your knees, wrapping your elbows, something like that maybe the patient hadn't thought of, something that they've just been taking medications for their knee pain without trying something simple as joint support. Decreasing stimulation, helping patients see what their triggers are and helping them realize how to decrease them can be very beneficial. Patients might not have sat down and looked at their day and see what they need to do to decrease that generalized pain. Music therapy, as I mentioned before, something simple as a bone marrow biopsy, putting the patient's favorite song on can change their entire perception of that procedure and can really change how they leave that day. PT and OT, mindfulness meditation, Reiki, and healing touch, which are available in many major institutions now and can be used inpatient. Stress management and distraction techniques, acupuncture and chiropractic, immobilization and rest, weight loss for something like chronic knee pain, low level and high level laser therapy, cognitive behavioral therapy, reflexology. And the number one thing that I always try to explain to patients is environmental optimization. That's something that they can really be empowered to do with themselves and their family, is fixing their environment to creating a world that their pain is not the only thing they are focusing on. If these are acute pain patients and they're recovering after surgery, the environmental optimization is key. Having them have support on the stairs, support in the bathroom, support to get in and out of the car, those things help avoid that pain trigger and help make them move more, which improves their outcomes. Next slide. Improving functional ability and really having a personal postoperative goal. It helps keep the patient's eyes on the target and to reach their discharge goal, and showing the patient that they can utilize non-opioid techniques and opioid techniques if they need to, but it's giving them like a toolkit of things that they can do to manage their pain. Next slide. We have to use opioids in medicine. It's something that you cannot completely avoid, right? And it's something that you shouldn't try to avoid, because undertreating pain is equally as dangerous as overtreating pain with opioids. If you undertreat acute pain, the risk of that patient having chronic pain is significantly higher. So it's very important to treat acute pain effectively, which sometimes can mean using opioids. Discussing using opioids prior to the intervention is key. Ensuring that the patient knows you never give opioids around the clock. You use opioids as breakthrough pain relief. And once the pain is controlled, you utilize the opioid to prevent that 10 out of 10. And developing a realistic pain goal with patients is critical. If this patient is going into major surgery, it's critical to have a realistic pain goal. A 0 out of 0 pain is not realistic when you've just had surgery. Establishing the goal of a functional, tolerable pain is very important, so that you have the conversation with the patient. The goal is to walk. The goal is to be able to get out of bed. The goal is to be able to conversate, to be able to sit there and enjoy the weather. It's functional goals that are extremely important. And utilizing the opioids to optimize activity. So discussing with the patient, if you're in so much pain, all of your other non-opioid medications are not due. All of your other non-pharmacological interventions, you've already tried, none of them are working, and you cannot get up and do your walks, then you can utilize your opioids, because that's appropriate. I do highly discourage saying to patients to utilize opioids for sleep. It can cause a negative connotation that the patient then views that opioid as something that is scheduled before bed, which scheduling an opioid like that with somebody in acute pain is just risky for a risk of dependence. So I always encourage patients to utilize the opioid as breakthrough pain relief. And as a provider, you make sure that the patients are asking questions and you're answering them. Like, what are their side effects? What are they going to experience? What do they look out for risks of dependency? What signs and symptoms should their family be looking out for risk of dependency? And what do they do going forward? What are the support? What resources do they have after they are home? Next slide. As patient to providers, it's important to just describe what you're feeling, to use descriptive adjectives so the provider can appropriately treat the pain. For example, describing the difference between surgical pain in the abdomen versus surgical pain in the shoulders is very important. Describing adjectives helps tell us which medications are most appropriate. And the patient has to be transparent with their communication of their pain level and their willingness to communicate their pain. Provider to patient, we need to be aware of communication barriers. We need to be aware of our own stigma and aware of the patient's tolerance and cultural awareness and cultural bias. We need to be sure that we're not under-treating a patient because we think that they are seeking. That is something that's seen very frequently. And as I said before, under-treatment of acute pain leads to a higher risk of misuse and a higher risk of chronic pain. Next slide. So opioid safety in the home, it's very important to teach the patient to avoid hyper-awareness of time, to utilize the non-opioid options, safe storage, appropriate disposal, and identifying their realistic expectations and their goals. Next slide. And just self-awareness, awareness of their needs and individualized anxiety support. It's always important to have a second check person or a gatekeeper. As I said before, some of the first opioid prescriptions for patients are after sports injuries or after a dental procedure, and many of these patients are young. So it's very important to have a gatekeeper or your second check person that's keeping an eye on your use of those opioid medications. Next slide. Key takeaways: use a multimodal approach for pain management. So utilize multiple types of medications to reach all pain pathways. Adding complementary and alternative approaches provides well-rounded care and gives the patient their own toolkit that they can use to manage their pain. Advocating for medication availability within hospital systems, example, IV acetaminophen. If your hospital system doesn't have it, advocating for that can really change outcomes for patients. And early utilization of other practitioners, early utilization of support services like pastoral care, integrative medicine, PT, OT, pain management, and your pharmacist. Incredibly important to get them involved. Next slide. That's it. Thank you very much for your time.
Thanks so much, Sarah. And Dr. Bailey, I know we're coming to the end of our time, but both of you had such important information that I appreciate you sharing it with us and utilizing the time. Quick question that we're getting in the chat. You talked about, both of you talked about being aware or having conversations. What are some of the signs and symptoms that family members should be looking for, that practitioners should be looking for, and what the patient themselves should be looking for? So I don't know, Dr. Bailey, do you want to go first? And then Sarah, will go to you to give you a minute.
Yeah, so you were saying signs and symptoms of like misuse?
Yeah, or dependency or
dependency.
addiction.
Yeah. So, I mean, one of the things that we always look for is overutilization. So if somebody is calling the office saying that hey, I need a refill 3 days early, that's a problem. And it's something that really has to be addressed in a constructive manner, rather than kind of being punitive on the patient, because we want to see like why are they going down this path. Another sign of misuse is really, as kind of Sarah meant, like a preoccupation with their medications, and like she was saying, like taking it around the clock. I've had a patient whose family members would call them in the subacute rehab to wake them up to ask for their opiates. That is not appropriate. Yes, I would say, Sarah, I'll pass it to you too.
I would say as a family member, I think the biggest thing to look out for would be your family's inability to continue to function throughout their day without taking it. And it's not in a response to pain, it's just in response to the schedule. That would be the biggest thing for me, is if you're noticing your family member says like, oh, it's 12 o'clock, I have to take it,
Okay.
and not in response to the body.
Okay. One other question, and then I'll give you guys a chance to just do a final thought. You both mentioned the cultural differences or cultural influences that maybe you should deal with pain more, or if there's gender issues. Can you touch on those? Again, Dr. Bailey, I'll go to you first.
Yeah, I mean, I would say every patient approach is individualized. Yes, if there are cultural issues or like stigma related to this, especially with buprenorphine, patients see buprenorphine, they hear me say it, and they say, "Hey, I think that's the same medication that you give to opioid addicts." And I say, "Yes, that is correct. However, I'm using it in a different formulation, in a different way to help you with your pain." So, I would say it's really about education and meeting the patients where they're at and seeing what they're willing to incorporate into their treatment plan, as long as it's safe for them.
And Sarah.
I'd encourage providers to be aware of their cultural bias, of the patient's perception of pain too, of the conversation that you can sometimes hear of there being dramatic. That culture is always dramatic about pain, because then you tend to not actually listen to the patient and hear what type of pain they're experiencing. And if you're not truly understanding what they're experiencing, you're not going to treat it appropriately.
All right, thanks. And at the end of our time, so Sarah, I'll give you a chance. Any last thoughts? I know your presentation was so comprehensive, but anything you want to leave with our attendees today?
Just the biggest thing for me is really getting the patient involved, learning your patients and getting as individualized as possible. Because if you don't do that, you're not really taking care of them as best you could.
All right, thank you. And Dr. Bailey.
So I would say that the treatment is only as good as the diagnosis that you make. So please work up complaints. Do not attribute new pain complaints as to an old problem. We see this all the time. To just work up your patients, make sure you know exactly what you're treating.
All right, thank you so much. Thank you so much again, Sarah and Dr. Bailey, for that great information that you provided. For all of our attendees, thank you for joining us. A copy of today's presentation, a link to the recording, as well as a copy of the slides will be provided to you. Again, please refer to the slide on your screen now for information on continuing education credits. Again, I know we have a lot of different categories, so please make sure you click on the link that applies best to you and the credit that you need. I hope that you can join us next month. On June 20th, we're going to be discussing opioids, the impacts of health disparities and discrimination. And as we continue to discuss, the opioid crisis and what we're seeing and how it's evolving, I think this is a really important part of the conversation. So I hope that you can join us again on June 20th. Thank you again to our expert panelists. Thank you again for all of our attendees, and be well, everyone. Have a good day.